Okay, good morning, everybody, or good afternoon, depending on which corner of the world you're joining us from. I want to extend a very warm welcome to you for us to have a public discussion on the recent NHIF Amendment Bill 2021. And we're very excited to have you here. Before I introduce my guests, a few house rules. If you want to ask a question, you can either ask it on the chat or the Q&A button at the bottom of your screen. So feel free to ask questions and we will respond to these questions towards the end of the webinar. And so without further ado, we shall start. So joining me today, I am very happy to be joined by my distinguished guests. And firstly, I'm going to introduce myself. My name is Sheila Gatu. I am a fellow of the Institute and Faculty of Actuaries, and I work for Zamara, Rwanda, as the resident actuary in Rwanda. And I also live in Rwanda. I am honored to be joined by Dr. Mwangangi, who is the Cabinet Administrative Secretary at the Ministry of Health. I'm sure she's no stranger to anybody in this webinar. And so we're very happy to have Mercy with us. We also have Ezekiel Macharia, who is a fellow of the Institute and Faculty of Actuaries, and he is the CEO of Kenbright in Kenya. He also happens to be the head of the Health Working Party under the Actuarial Society of Kenya. Thirdly, we have Sahib Khosla, who is also a fellow of the Institute and Faculty of Actuaries, who is an academic and consulting actuary at Strathmore University. And we are glad for him to be joining us as well today. And then lastly, we have a representative from NHIF, Wambugu Kariuki, who is the acting manager for registration and compliance at NHIF. And so could one of the panelists please tell me if you're seeing me clearly? Are you hearing me clearly? Maybe Ezekiel?
Yeah, you're clear. We can hear you. Please proceed.
Great. Okay, so I will just introduce our session today with a few pointers on what we'll be discussing. Now, very importantly, we are going to be looking at universal healthcare and how Kenya is going to achieve universal healthcare. So universal healthcare is about ensuring that all people have access to the needed health services that they need of sufficient quality, and also making sure that as they receive this healthcare, that they are not exposed to financial hardship. And so if you look at this square that we have over here, we are basically making sure that under universal healthcare, the whole population is covered. They are covered for all services, including inpatient, outpatient, and so on. And they are not exposed to financial hardship as a result. So what is the Kenyan journey in terms of universal healthcare? Well, our government has prioritized universal healthcare in what we call the Big Four agenda. And so this is a very important priority for our current government. We also have numerous studies that have been done in order to inform the government about the viability and practicability of implementing universal healthcare in the country. So we had the Health Benefits Expert Panel that did its work in 2018. We've had numerous actuarial studies, and the NHIF actuary actually happens to be here with us, Ezekiel. And so he has done numerous studies on the financial viability of NHIF. We also had pilots in 4 different counties in the country to be able to test and see how the universal healthcare would work. And then in 2019, we had an expert panel called the Health Financing and Reforms Expert Panel that looked at different elements of how to achieve universal healthcare. And I happened to be a part of that panel. And all this has now culminated into the NHIF Amendment Bill 2021. Why the NHIF Amendment Bill? Because from all the studies, it is very clear that NHIF has to be the implementing agency for universal healthcare. So what are the main features of the NHIF Amendment Bill, which is supposed to prepare the country for achieving universal health care? The first thing is that there's the introduction of mandatory contributions for every Kenyan resident, with the government contributing for the vulnerable. So right now, it is only mandatory for the formal sector to contribute to NHIF, but under this bill, the proposal is for mandatory contributions for every Kenyan. Now, of course, the question would be, why does NHIF need more money? The thing is, all these studies that I mentioned before have noted that NHIF's financial viability is actually under threat due to the fact that the claims that they pay out are normally higher than the contributions that they receive. Specifically for what we call the super cover, where every Kenyan pays, where the informal sector pays 500 shillings per month, it has been noted that for every 100 bob, every 100 shillings that a member contributes, 250 shillings is paid out in claims for that particular member. And so that is the first thing that is important to note that this bill is trying to address. The financial viability of NHIF is not very safe. And so the fund needs more funds for it to be able to achieve universal health care. The second thing is the introduction of mandatory employee contributions as well as employer contributions. So currently it's only employees who contribute, but now there's going to be the introduction of employer contributions. Thirdly, there's a new relationship between private insurance, a new relationship with private insurance in the payment of claims, and we're going to go much deeper into that. Fourthly, there's an improvement in the governance of NHIF. Right now, the board salaries will be paid in line with the Salaries Remuneration Commission. The CEO qualifications have been improved, and assets of the fund are not liable to attachment. Lastly, there's a lot of improvement in the transparency of NHIF. For example, the list of empaneled providers will now need to be gazetted. And so as I sit where I am as an actuary, I really want to just commend the government for all the work that has gone into this, and because universal healthcare is important, and I can say that we are leading the way in Africa. And I mean, the spirit behind the bill is a really good one, and I believe most of us are in agreement that what the bill is trying to address is crucial for every Kenyan. So what this webinar will focus on is mostly on the practicability of implementing universal healthcare. And so without further ado, I will start asking our panelists some questions. And the first thing we're going to focus on is the availability, the affordability or the fairness of contributions. And this first question will go to Dr. Mwangangi, our Cabinet Administrative Secretary for Health. Now, Mercy, the Parliament Budget Office has now approved the 6,000 shillings per annum per household mandatory annual contributions. And we are assuming that the formal sector contributions will remain as they are. So this will be a new thing for the informal sector. So the question on many Kenyans' minds is, if you look at other countries such as Rwanda, when they started achieving universal health care, they already had a pre-existing system that divided the population according to their income. It's called the Ubudehe categories. And so that was already pre-existing before they started implementing universal health care. But the question is, in Kenya, we do not have such a system where we are actually divided as a population into our income levels. So Mercy, please tell us, how is the government and the Ministry of Health planning to ensure that this 500 bob, this 500 shillings is fair for every Kenyan based on their affordability to pay?
Thank you, Sheila, for this good question. And let me also thank my fellow panelists for joining us today, and for the organizers of this meeting, because these conversations are encouraged from the standpoint of government. These are conversations that we are encouraging because we recognize that UHC really is a journey. And let me start with that word, journey. Different countries across the world are in different levels of progress when it comes to the UHC journey. Much of the work that we do within the Ministry of Health, within NHIF, is work that is pegged on extensive assessments of what best practices are across the world when it comes to the UHC journey. And I'm pleased because I'm here with actuaries today, particularly seeing Mr. Macharia. All of you are people who are well versed in the journey that Kenya has been taking when it comes to UHC. And most importantly, with those countries who we benchmark with. For example, Thailand, for example, Japan, for example, part of the UK system in what they do, and also learning from countries where they've not been able to perhaps mitigate some of the challenges that they've encountered when it comes to UHC, e.g. Obamacare in America. Now, when it comes to the 6,000 Kenya shillings, we are aware, we saw this figure within the social media pages, in the media, and Kenyans were asking, how did we come to the determination of 6,000? And I'm pleased that Sheila, you've done a very good background to share and share with the participants today where our evidence base is coming from. If we go all the way back, perhaps even close to 12, 13 years ago, and look at the contributions that were being made to NHIF, we can see that there was a steady increase, one, in people who are enrolling into NHIF, but two, even in the demands of those beneficiaries who are enrolling into NHIF, up to the point where you've aptly shared, Sheila, that for every 100 shillings that is being contributed, we are having 250 shillings being paid out, meaning we are already in a state where we are making losses as a fund. Now, through a lot of engagements and stakeholder collaborations, negotiations, some time back, Ezekiel would know this better, NHIF was able to move one of its contribution rates from 150 to 500 shillings. And that was monumental. And one of the things that came about after moving that figure from the 150 shillings to 500 shillings is that you've seen the introduction of new benefit packages in NHIF. I can tell you on every single day, we get requests from individuals, from the public, who are looking, for more extra support from NHIF, but also who appreciate that NHIF has been able to take care of their needs when it comes to dialysis. NHIF has been able to take care of their needs when it comes to cancer and oncology care, when it comes to surgical packages. And so really, it's tremendous, really, the effect of moving from 150 shillings to 500 shillings, and of course, then the putting in place of new benefit packages. We have conducted a bit of, we have conducted extensive research when it comes to what is the optimum contribution that a Kenyan family should be able to pay, to NHIF to be able to get a benefit package that is comprehensive. And we had a team of actuaries sit and come up with this determination. Some of these figures were jaw-dropping. Figures talking to the extent of almost 20,000 for a Kenyan household to be able into the now, and the 20,000 from which our experts told me that this is the amount that would be required to be able to then give this package to Kenyans. And what we are saying is right now, with the processes that we're putting in place, particularly in the NHIF amendment bill, is that the key words, which we must all note, is that it is time for progression. The journey for UHC cannot be attained when we pedal on the same space. Yes, indeed, we will share with you, and I'm happy to be here today to share with you the numerous reform agendas and implementation activities that are within NHIF. And my colleague is here, Wambugu, as well. We'll be sharing with you what we've done to ensure our systems will be robust. But what we are determined in terms of moving this forward as government is that, yes, we need to start from this point. We start from the 6,000. We've been able to do exercises to determine what can 6,000 buy you in terms of entitlements, but we appreciate it is going to be a progressive journey. We will not be stuck at 6,000, but right now it is a good starting point because already we have super cover in place and the benefits are good benefits, which Kenyans have given us feedback and do actually appreciate the benefits of super cover. So my keywords here really, which I want people to remember is that it is a journey, it is progressive, and we cannot keep on pedaling. We have to continue investing in the fund because it is indeed what, as you said, Sheila, the key implementing agency when it comes to UHC. Sheila, over to you.
Thank you, Mercy, for that. So just to elaborate further on that, I believe that's clear that, we do need the 6,000 per household in order for NHIF to continue the good work that it's doing. just to build up on that, so the NHIF amendment bill says that the government will actually pay this contribution for vulnerable households. So they list vulnerable households as the orphaned and vulnerable children, widows or widowers, poor elderly persons, indigents due to the risk of abuse or neglect, who have been identified as such by the relevant government body. So I would ask, there are some members of the society who would not be obviously considered vulnerable. I'm thinking about somebody in the village, a woman who is married to somebody who has an income. And so probably according to the government, it seems that, you know, this family can afford the 6,000, but maybe this man spends it all on alcohol, for example, right? So my question would be, how are you going to identify who is vulnerable so that you can say, okay, for this particular person, government will contribute for them?
Thank you, Sheila. I realize, you know, the first question was quite heavy, and that was just, should I say, the beginning of our conversation. And you raised an important point when it came to your experience, particularly in Rwanda, when you look at the system there and the identification system that is there within government. One of the things that we are doing, the reforms that are within the health sector, perhaps translate into broader government reforms. We have teams, and particularly under the Ministry of Labor, as well as you know, beyond the Ministry of Labor as a whole of government approach, mechanisms in place to actually be able to identify our population when it comes to income status, to be able then, of course, to extend this ability towards widening the tax bracket, in terms of ensuring that we're really mobilizing taxes, particularly those who are able to pay taxes, for them to be netted into that tax bracket. I'm sure those of you in Kenya do appreciate that we do have the Huduma Number Initiative. The Huduma Number Initiative is one which will soon be finalized. In fact, I think people have already started receiving messages to receive their Huduma number cards. Part of that system is that we will be able to then have what we know as a unique identifier for Kenyans. And this is going to be then pegged together with your NHIF contributions and status, but also your tax status. Are you paying your taxes? Where are you getting your sources of income? And through this mechanism, again, keyword, progressively, we shall then be able to have a database where we're able to identify who is this vulnerable Kenyan, who is this vulnerable Kenyan, and to what level are they vulnerable? And additionally, if they are vulnerable this year, will they still be vulnerable next year? And so it's important to appreciate that this will be a dynamic and a changing metric. Every year, year on in, we'll be evaluating and determining who are those people who we need to pay for. As it stands today, right now, I'm very proud. NHIF has made good headway. They've already identified close to 700,000 poor families across the country. And this was done in collaboration with the Social Protection Secretariat, as well as our partners in the Ministry of Health and the Ministry of Labor. We have a very elaborate identification tool. It is a tool that is able to then undergo means proxy testing at the community, together with the administration in the communities, and define who are those poor households. And the beauty of this tool, and I can tell you, having undertaken this exercise and well aware of the different constraints that come about, is that this is a tool that is community validated. I'll give you examples where we were in Kisumu County identifying the poor, and the people in that community are the ones who actually come up and tell you, indeed, your tool has identified these 5 people, but these 2 people here, these 2 households, those are the ones who are most at need. And in fact, we encourage you to mop them up and pay for them. And so we are very happy with the progress we've made. Like I've told you, shortly within 4 months, we already have 700,000 families. Our target this year is 1 million. We are sure within the next few months, we should be able to mop that up and ensure that these families therefore then get a subsidy. Now, we're already 10 steps ahead. We have our first batch of 700,000. We're already asking ourselves, will these people still qualify for this card next year? And so there is a mechanism, again, linking up with Huduma Number to ensure that this exercise of validating the vulnerable will be undertaken at least on a 2-yearly basis within the country. Remember, vulnerabilities in terms of our country and the subsidies that government offers are not limited to just an NHIF card. So this system is actually going to triangulate the family that is getting, disaster and disease food, is it also the same family that's getting the NHIF card? And so there's a lot of elaborate work in the background to ensure that at the end of the day, Kenya will actually have a database that is able to identify the poor. And again, of course, the added benefit of working with KRA to ensure that we net in and expand our tax net. Now, the second thing that you've mentioned was very, very important. Once we've identified and been able to have this database and particularly have granular data when it comes to income levels within the country, how will the contributions look like? And what we are learning from best practice the world over is that it is always important, one, as a principle of insurance, that the rich pay for the poor, the young pay for the old, those who are not sick are paying for those who are sick. And so the end of the biggest, grandest, should I say, principle we have is that everyone must be in this pool. Each and every Kenyan must be in this pool because we need to leverage on those economies of scale. That's lesson number one. Number two is that contributions should be pegged on your income. And this therefore means that if Mercy is earning 100,000 Kenya shillings and is paying 500, and Juguna is earning 20,000 shillings and paying 500, then we are being unfair to Juguna. And that is something we have to agree upon as Kenyans. I think it is in the spirit of who we are as a people, but most importantly, even technically, in terms of evidence. Look at Japan, look at Thailand, their scales are graduated by income. And so this will continue going forward. This will be revised in terms of income levels. But another important caveat with your engagement and your collaboration and your negotiation, so that we can work on this in terms of ensuring that UHC makes steps towards UHC. I mean, that the country moves towards UHC. I think we all appreciate the merit of UHC, particularly now with COVID-19. I can tell you early on in April, lots of the cries were both from the insured Kenyans and uninsured Kenyans. Government, can you step in and take care of us? And the only way we could be able to do that, and the only way we can be able to guarantee that in the future, is if we invest towards NHI. Thank you.
Thank you, Mercy. You've actually answered my question, and I think what everyone has been able to gain from that answer is that we shouldn't take what we read on the media at face value. And I think my take home from there is that it's a journey. Nothing is cast in stone. And so there are studies that are being done and they will continue to be refined. So as we wrap up that section on contributions, I'll invite Ezekiel to just give his comments and confirm what Mercy said. If the formal sector is continuing to contribute what they're contributing, employers are also contributing, and then there's the around 500 shillings per month per household, will the NHIF be viable? Ezekiel.
Thank you, Mercy. So to answer that question, I think the best thing to do would be to do a slide for the members. So I have prepared some slides, one slide for the members to see. So I just put some commentary. And if you can see my screen. Sheila, can see my screen?
We can see your screen.
Okay, thanks. So mine will be very simple. I will be talking about claims experience of that scheme, of that voluntary scheme. I'll give you an idea on the loss ratio. I know you talked about 100 to 250. I'll talk more about that. There's a serious moral hazard in the scheme. I'll also give you some key statistics and also answer the question, is 6,000 enough? So, well, the first information is that it's a bit sad right now because people who contribute on the voluntary scheme as of 2020, they gave about 6 billion to NHIF and took out about 11 billion. So in terms of loss, just from that scheme alone, ignoring management expenses and capitation costs for outpatient, these schemes were costing NHIF about 5 billion shillings. Now, the sad news is that NHIF cannot afford another 5 billion loss. So think of this bill as a rescue package because solvency dropped below 100%. So unless NHIF plans to sell its building, this voluntary scheme is actually eating it to the ground. And just to give you an idea of this 5 billion shilling loss, the largest private insurer made a profit of 600 million only. So this loss is nearly 10 times that profitability level. And it's quite catastrophic. It has been going on for 3 years. Now, remember, these schemes are set in law by Parliament, so there's nothing you can really do. Even if you can't edit it, the only thing you can do is just see what you can do with it. So they have been trying to do other things about waiting periods, but as you're aware, those things have been blocked. So we deep dived into this loss and said, what is really causing the loss? So we looked at it. So if you just look at on the left side, you have the contributions and claims, and then on the right side, you have the loss ratio, and you can see the loss ratio for this group has been playing around the region from 2017, where it was as high as 300%. So for every 100 shillings, it was 300 shillings out of the door. It went slightly downwards, but it's still at 200 shilling level. There's a serious moral hazard on it. So we also analyzed what are people claiming. Just to give you a commentary, a third of the people don't pay beyond month 3. So people come in, pay 500 shillings for 3 months and exit. They go get a big claim on cancer or maternity and then exit the scheme. So what we did is we looked at people who just contributed for 4 months only and exited, people contributed to 15 months and even 36 months at the end there. You can see who are these people. So you can see people who claim for 4 months, who just gave 4-month contribution and exited. You can see at the top there, one of the key things we noticed was maternity claims. So people would go in, you know, you're having a child in 4 months' time, you go pay your 500, you go claim your 50K or 100K and you exit. So you can see the maternity curve there is slightly higher in terms of proportion of how much money people are spending. From the maternity group, it was high for the people who are entering. People who are staying that 6 months, you can see they're not spending much on maternity. Look at cancer, which is the gray area, cancer and renal package. People who are just joined, come in for 4 months and leave, very few, about 10% of their claims are for cancer and renal. But you can see people who have stayed in the scheme, about 25% of their claims are for cancer. So you can see there's a bit of moral hazard in terms of, since people can enter and exit the scheme, that is where that high loss ratio has come about, because of that issue of there's no control. So we also deep dive into that same group, and so this is really my last slide, which shows you membership. So we've split it into 3 groups. So to make you understand this, what we've done is on the left side, we have taken the cohorts. How many people came into NHI for 1 month and left? How many people came into NHI for 12 months and have been continuing to pay? And then also we gave the membership numbers. So you can see 2017-18, about 1.2 million people. 2019-20, about 1.54 million people. Then we also look at the admissions, how many people went to hospital. Then we also look at the admission rate as a proportion, how people are being admitted to the population, how much they give NHF in terms of Kenya shillings, how much they claim, what is the loss ratio. So if you just look at the guys who just came in month 1 and exited, you can see for 2019-2020, they're about 190,000. Just to give an example, what that number is, 190,000 is larger than the number 3 private insurer. That's a large group of people. So they came in 190,000 people, 16,000 of them went and got admissions. So there's an admission rate of about 9%. Contribution total was 90 million, but they claimed 500 million shillings. So you're seeing there's a group of guys who came in, paid 500 bob, claimed 500 million and exited the scheme. So that was really very, very high. And you can see the same trend. So the last page on the end, the loss ratio just shows you how that loss ratio is dropping as more people staying. So people who stayed, who have been loyal and have stayed in NHI for 12 months are about 625,000. They're about admissions about 155. Key thing to note there, look at that admission rate, 25%. So for the people here who do pricing for private insurance, you all know the average rate is about 12, 13%. So you can see this is a sicker population. So the rule here is that the sicker people are staying and the healthier people are leaving. So you can see they have given 3.7 billion to the NHIF, but they have claimed about 5.5 billion. So you can see the loss is about 149%. So the key thing to note is we have 2 groups of people. We have people coming in, claiming and leaving, and we have the sicker people who are staying in. So what is doing that is grinding the fund, and the fund, as we indicated earlier, the surplus is over. So the fund has to take action. Otherwise, even if this bill doesn't pass, there might be no NHIF. I don't think they will want to sell that building to pay medical claims. So with that, the question Sheila asked, is 6,000 enough? Well, member who contributed for 12 months, loss ratio is 165, just for that group alone. Healthy members leave the scheme while sick members stay on board. Sickness ratio for healthy people is 13% compared to 25%. So if you just work backwards, you do some actual math there, you notice that if membership was made mandatory and moral hazard was reduced, the loss ratio would drop to about 85%. So 6,000 is just break even because the admin expense for NHIF is 15%. So it'll just be break even. It'll just be enough to pay claims and be, just to stay afloat. But there needs to be an inflation adjustment for that. And I don't know about means testing, but for us, in terms of we just look at the same cohort, if you're to make them pay just the group that are in, things would be profitable for the scheme. So with that, I will hand back to the team to move ahead.
Okay, thank you, Ezekiel, for that comprehensive discussion. And so basically from that discussion, it is clear that NHIF needs more contributions if it is to survive. And the 500 shillings is a good start. So let's now talk about private insurance. I'm sure almost half of our audience is from the private insurance sector. And of course, they have concerns that have arisen because of this bill. And so I will direct my first question on private insurance to Wambugu. Wambugu, tell us about the UHC benefit package. Will it be similar to what is currently there for super cover? Will it be similar to what the private insurers are offering? And maybe just give commentary on how that benefits package was chosen and whether private insurers should be concerned that, there'll be no more need for private insurance if based on this benefit package of NHIF.
Thank you so much, Sheila, and I want to say hi to everyone in the panel. I'm happy to be in this discussion on this day on the NHIF Act amendments, and especially as a country as we move towards full implementation of the UHC. And maybe from your opening comments, maybe just to, and even align to the question you have just raised, just to make just a few clarifications, especially one in regard to the super cover. Actually, the super cover is the benefit that is available for every Kenyan contributor, not just for the informal sector or the voluntary contributors. It's actually the benefit that is available even for every one of us who is deducted monthly from their payslip. And it's also actually the benefit that even those who pay voluntarily, the category that Mr. Ezekiel has emphasized on, they have access to. And the NHIF Act amendments that are happening, of course, there's a lot of new things that had to ensure that as we implement UHC, even from the presentation that Ezekiel has done, then we want to be sure that we're implementing a UHC that is going to be sustainable. Now, but going straight to the issue of the super cover versus the UHC benefit package, maybe just to give a little bit of history is that when the discussion on UHC was started, there was a panel from the Ministry of Health, a panel that had been formed to be able to actually propose a benefit package for the UHC. And they were able to come up with a proposal for a benefit package, a team that was headed by Professor Kokwaro. Then, of course, NHIF has been implementing the super cover since the year 2015, when we enhanced our benefits from the previous a maximum of up to 320 to the current one, which goes to about 1,700 for those ones in the formal sector. So from that point now, after the decision was made that after the pilot that was done in 2018-19, the scale up of UHC is going to be done through NHIF on an output financing model. Then we had to compare what had been proposed by the Health Benefits Advisory Panel and also the NHIF super cover, so that we're able to come up with a harmonized package that we should be able to offer to the members. And it's from that we actually, I would say more or less is actually the same with a bit of enhancement for the UHC benefit package. Currently, the super cover has 10 benefits. In the rollout of the UHC, it is going to actually have the same 10 benefits, but other benefits that will be starting out in the UEC benefit package will be, for example, a benefit package for chronic illnesses. That benefit is currently covered either within the outpatient cover or like the inpatient cover, but now it is going to start out as a benefit package by itself, so that, because that is one category of beneficiaries who have been feeling like they have not really been catered for well. And then we have the mental illnesses package, which again, we in the discussion that were there between the Ministry of Health and NHIF in coming up with the harmonized benefit package, it was felt again we needed to come up with a benefit package for mental illnesses, and now that one is there as a benefit package under the UHC. So I would say that from the 10 benefit packages in the super cover, as we roll out UHC, we'll be having 12 of them, and that is we'll be having an outpatient cover, which is more or less like what we have currently under the super cover. Then, of course, I mentioned you'll be having the non-communicable diseases or the chronic illnesses cover. We'll have the inpatient. We'll have the maternity benefit package. We'll have the renal dialysis cover, the radiology, which will cover the MRI and the CT scan. We'll have a surgical package, which will have 3 components, the minor, major, and specialized benefit packages. Then you'll have oncology, which will cover radiotherapy and chemotherapy. And then we'll have the drug and substance abuse rehabilitation, the mental health package, the emergency evacuation, road ambulance evacuation package. And lastly, we'll have the foreign treatment package, which will be able to cover a member in case the treatment they require is not available locally. So that is the benefit package that the Kenyans will be accessing under the UAC benefit package, which, as I said earlier, is actually a harmonization of what was proposed by the Professor Kokwaro team and what NHF has been offering. Because, and of course, the major consideration, and even recalling the picture that has been put by Mr. Ezekiel, is that we want to have a package that can be sustainable. And maybe just to comment briefly on even that presentation is that we know that has been the trend, and actually it has been an issue of concern, looking at the trends, especially when it came to the informal sector, who are coming voluntarily. And as what you saw from the presentation by Mr. Ezekiel, these people would come in, they access a benefit, then they just leave. And it exposes the organization a lot financially due to that element of adverse selection. And that is now one major thing that the NHF Act amendments try to address, because as you'll note in Section 15, the proposed amendment of Section 15 of the Act is that contributions or membership to NHF and contribution is going to be made mandatory. Mr. Ezekiel will tell you that out of about 4,000 members under the informal sector, you find it is actually a very small percentage of them that are active, actually about 30%. And once this is made mandatory for everybody to enroll, and it's already clear that the government has come up with a mechanism, as it was explained by Dr. Mwangangi, that the government has been able to come up with a mechanism of identifying those who are not able to contribute, and then they're able to pay the premiums for them. So by just paying that premium for the vulnerable group, it actually takes that cohort of membership in terms of active members very high. And then making...
thank you, Wambugu. I'm so sorry to cut you off, but we're really running out of time. But you have actually answered exactly what I wanted to hear from you about the benefits package. And so I'll now take it back to Dr. Mercy. Given that, this benefits package will actually be an enhancement of what is currently offered under NHIF, how do you kind of address the private insurers on this call who are wondering, okay, so now it will be mandatory to contribute the employee contributions as well as employer contributions. So an employer will be in a situation where he now has an additional employee benefit to add to his expenses, right? And then even in the informal sector, they now have an option of NHIF. So what do you tell the private insurers who are thinking, okay, will this then mean that employers will now have to cut back on how much they are spending on private insurance? And what does this mean to the private insurance sector, which actually provides a lot of revenue even for the government, which is an important sector in the country? How do you sort of address that concern that they have that, this will actually significantly impact the revenue that they are getting, because it will almost be like NHIF is in competition, according to their fears.
Thank you, Sheila. And just to really pull back, follow the thread that Wambugu has left us with, is that to answer that question, we need to answer it in context. That's very important. We need to, one, appreciate what Mr. Macharia shared with us, that indeed right now, as it stands, we are in danger if we do not continue with ensuring that we are mandating mandatory contributions. That's one. And two, of course, also increasing the revenue base by exploring how we can do matching. So we all need to appreciate that fact. I think also we need to appreciate this fact on the background of who are these people who actually get the service from NHIF. One of the last assessments that we received from the expert committee gave us a figure of about 20% of Kenyans being insured, of which a fair majority of those, close to 18%, are those who are insured under NHIF. And so even when we're looking at this question in terms of the greater public good, it's important we all appreciate at the beginning of it all that this fund really is there to serve, to provide health for Kenyans and to serve the greater public good. I think that's very, very important. Number two, at no point has anyone in government or even within the bill itself, at no point has there been any indication or leaning that we're trying to disinvest the private sector from dealing with medical insurance. In fact, if you look at the detailed HEFREP report, you will come to learn that across the world, best practice is that there is usually a thriving ecosystem between social health insurance funds, and their private sector insurance funds. I'll take an example of Australia. In Australia, you are actually supposed to be enrolled in the Medicare program, but also it is expected, and there's a surcharge if you do not have private insurance cover, particularly if you're of an income of if your income grading reaches a certain point. And so this is the same thing that we'll be envisioning in Kenya. NHIF will continue to exist in an ecosystem that will thrive as well with private medical insurance. And the question we should be discussing, and one that really I'm encouraging, that perhaps beyond this webinar, I'm now appreciating the need of several more interactions and engagements with the private sector players, is to then sit on the table and understand how will this look like. One, Wambugu has shared the benefit package. I think during a second session with yourselves, we would need to then tease through the granular details of this benefit package. He's talked about mental health. He's talked about looking at NCDs. Now, if we look at that NHIF benefit package, have we sat around the table and comparatively looked at it with those that are offered in the private sector? We've not done that. And when you do that comparison, you'll come to see that in as much as this is actually a welcome progressive step for NHIF to expand their benefits, still there's room for private medical insurance to thrive. I can tell you, one little funny story. I was in Thailand about 2 years ago looking at their benefit package. And one of the things we learned there is that increasingly every new year, they continue adding more entitlements in their benefit package. And how they do it is in good relationship with the private medical insurance agencies there, to the point where right now private covers actually offer you a massage service in Thailand. That's the dynamism in terms of how they've sat together at the table and looked at the benefits and come to an understanding. As it stands today, and I can tell you, in fact, one of the president's comments on this was that make sure we provide a proper ecosystem that will ensure symbiosis between NHIF and the private medical insurance. And that's what we are doing. And we are happy to really sit and engage with you, share with you a very granular element of this benefit package so that you can understand it. So that as you design your benefit packages, then you're aware of what we are offering under NHIF, and you're able to then be adaptable in the design of that benefit package. That's very, very important for us to understand. So this is the beginning of a conversation. Over to you, Sheila. And I must apologize getting calls from the office. I may have to leave in about 10 minutes, but we can continue.
Okay, no problem. And thank you so much, Mercy. I think we are very relieved. I'm sure most people on the call are relieved to hear that there is room for dialogue with yourselves, and I will take that up. I will take this up with you after this. And I guess the discussion will extend also to provider payment mechanisms in terms of, does NHIF pay first, or does the private insurer pay first, and so on. And so, as you said, that is a discussion for the next webinar, and so we'll pick that up. So as we're running out of time, I just want us to tackle 2 more questions. I will ask Sahib to comment. Now that Ezekiel has told us that the 6,000 will just ensure break even, does that mean that we are expecting future increases in premiums?
Thank you for the question, Sheila. I think what has been elaborated really well by Ezekiel and the team is that for now, sustainability can be achieved by the 6,000. I mean, the studies done, the numbers crunched show that you can break even, which is a good point to be at, as opposed to potentially, becoming insolvent. Does that mean that the 6,000 is cast in stone? I think, as has been alluded to by all the panelists today, it's a good starting point. Inflationary adjustments would come in. Again, it's not part of the bill as written, but again, as has again been alluded by the panelists, some of these things come through additional bills, as you can't tweak the fund as it is. And the proposal at this stage is to bring back the fund to break even, or at least being solvent, so that it can continue to provide the great services it has. Now, a question here would be, would that number fly high to what was discussed by the CAS in terms of 20,000? Again, progressive has been the word that has been used very well. Step by step, as we increase the benefit packages, as the members of public appreciate all the positive services they get from each facility that has been licensed. I think the general tendency for acceptance that this is a good use of 500 shillings a month will come more on society, and then adjustments can be made progressively to that. Okay.
Okay, so I guess a lot of what we are getting from everyone in this panel is that this is a progressive discussion. It's not a static number, it's not a static benefit package. It will be dynamic and change as the needs arise. And so thank you for that, Sahib. On to my final question before we take questions from the audience. And this actually addresses a lot of the questions that are being asked on the chat. Wambugu, please answer our final question. We have talked a lot about contributions, but what is NHIF doing? And as the CAS had to take a call, maybe you can answer this on her behalf. What is NHIF doing in terms of costs? So for example, we know that, of course, medical inflation because of medicine is very high. What is being done on that front? What is being done in terms of primary health care, so that we make sure that people are not going to higher levels of care for which is expensive? What is being done in terms of your systems? Can your systems actually handle universal healthcare in a cost-efficient way? Have you gotten rid of the manual systems? Is your system upgraded? Can you actually offer universal healthcare even to the remotest parts of the country? What assurance can you give us that when we are now collecting contributions from all over the country, that the medical costs will actually be controlled?
Thank you, Sheila. That's a loaded question. I'll go straight now. One, on the first issue of the costs, that what NHIF doing in regard to costs, and of course, it came out during the earlier presentation that the NHIF admin expenses have been a bit high, and of course we have been able to work progressively on that to be able to reduce them to the acceptable levels. As of course actuaries will say that it should not. The payout is expected to be about 85%. Now, automatically means that the amount of admin cost to incur should again never exceed, if at all, 15%. And of course, at some point, NHIF admin cost was a bit high to about 22%. That's about 3-4 years ago. But as at the close of the last financial year, we have been able to reduce that to 11%. And of course, among the measures that are being implemented to ensure that our costs remain low, one, in terms of administration expenses, is to actually to be able to implement or to adopt a technology-based system that reduces on the, because you realize that in any organization like NHF that is a service-based organization, a lot of expenses go towards personnel emoluments. And one way to reduce that is that we have been able to actually automate most of the system that would have required a lot of personnel in issues to do like enforcement of compliance in areas like processing of claims. We are now implementing a fully automated e-claim processing system, an electronic claims processing system. And that means it is going to reduce the intervention, the human intervention that are required to actually, we expect to about 80%. So eventually we will be able to actually have reduced numbers of HR such that the cost remain low. Of course, that does not mean that, because I know immediately you make such a comment, then people say that you're implementing system that you're going to retrench staff. But because this is something that is happening gradually, and of course, the normal natural attrition, the staff are also exiting, it means we continue enhancing efficient system that ensure that we don't need to hire any more new staff, but be able to work within what we have to keep reduction to that. And of course, we have also gone, as I have said earlier, in terms of implementing other systems by ensuring that the kind of cost that will go to processes like claims processing, the stationery and all that, now it is purely an electronic claims processing system that ensures that you're able to reduce on that. Now, in terms of payout, you also mentioned how are we ensuring that, again, the payouts are maintained at very fair levels. I mentioned earlier about the benefit package, and these are benefit packages that are being negotiated with facilities. This is a benefit package that has been computed by the experts. And now we are engaging with the facilities to negotiate and say, we are going to be paying you maybe 8,000, for example, for this procedure, and maybe 10,000 for a normal delivery. Then we negotiate with the facilities. And because of the numbers that are going to come with UAC, then we are sure that the facility is able to actually break even, and then we are able to reduce cost. Another way, of course, we are dealing with that is we are moving out from some of the traditional provider payment mechanism that we're using, like the rebate system, which again is expensive, especially when you come to long hospitalizations, like when it comes to cases like drug and substance abuse rehabilitation, mental illnesses. So we are coming now with provider payment mechanism that ensure you actually pay the actual cost of the treatment of that member. Now, going to the last question, which you asked in regard to the systems, NHIF, as I said, we have been on a journey towards UAC. It's not a journey that we can say has started in the last 2 years, but it's a journey we have been in. And just to mention a few of the, I would say a few of the reforms that NHIF has been able to implement towards preparation for universal health coverage. One, I would be able to say, and I've just mentioned that, is that we have implemented, we have expanded our healthcare providers network. About 4 years ago, we had only about 4,000 healthcare providers which are empaneled with NHIF. As we speak, there are over 8,200 facilities. That means Kenyans can actually be able to access care wherever they are. You mentioned the issue about our services being accessible even in the remotest areas. And I can assure you that of all the 8,200 facilities, which includes 5,800 government facilities, level 1, level 2, 3, 4, and 5, all those facilities are actually networked with NHIF. That means at any point when you access care in that facility, it is able to do a real-time notification to NHIF. That facility is able to actually submit the claim electronically, because of course the electronic claim system is actually being implemented gradually, but all the areas where we have implemented, like in the Western Kenya, even the level 2 facility can be able to notify on time and actually submit the claims electronically. Just, of course, I mentioned about the expanded service points network. Countrywide, we have about 156 service points where members can be able, all the members now at the UAC can be able to receive care. Of course, we're in the process of reviewing organizational structure and staff reorganization to ensure that staff are aligned to the skills that are relevant and are required for the purposes of UAC. Maybe just to mention the last one is, of course, the issue of biometric registration. Maybe Mr. Ezekiel didn't mention that one of the other major challenges we have been having with the NHIF are issues of fraud. And for us to be able to do with fraud is that we are actually implementing a biometric registration system to ensure that members who access services are actually able to be identified at that point, to be sure that we're only giving care to the people who need it. And of course, continually, we are also engaging our members through self-care platforms so that members don't have to visit NHIF for care. They can be able to go through a self-care platform and be able to make any inquiries, be able to choose facilities they need to seek services from. And that way, we believe we are so set and actually ready. to actually be able to offer UAC to Kenyans. Thank you, Sheila.
Thank you, Wambugu. I've just seen two questions on the chat that are related to systems. Number one, you've explained this very well in terms of how prepared you are. Will all those systems address fraud? Because that's normally one of the biggest issues in medical. Will the systems address fraud? And then secondly, let's say I and my husband are both in the formal sector, for example, or even in the informal sector, and the contribution is supposed to be per household. How do you ensure that you're only collecting contributions from one of us, and not that you're contributing from both of us, but there's some families where it's only one household contributing, but they have this access to the same benefit?
Thank you, Sheila. Now, on the first questions on whether the system that we are putting in place are addressing fraud, I think I'd already even alluded to that in my previous response, that we know that one of the areas where we have been, the area of fraud that we have been experiencing or we have been exposed is in regard to issues to do impersonation, issues of ghost patients by healthcare providers. And the ministry introduced biometric registration. It means that the person has to be present in the hospital for them to be able to receive care, and for the facility to be able to submit that claim electronically. So by just introducing biometric registration, then to a big extent, you are actually able to reduce on issues of fraud. Other areas of fraud is in terms of exaggeration of bills. And among the other areas of reform that NHF has done, and maybe I didn't mention this area, is that we have introduced a case management division that where we'll be having case managers who are actually pre-authorizing benefits on real-time basis for most of the benefits that in most of the areas that we know we have been exposed to fraud, especially in areas of the oncology care, the area of surgical, the areas of radiology. So those cases will be required to be pre-authorized by our case managers before care is given. So you are able to actually reduce the kind of fraud that we have been experiencing in those areas. So the systems are in place. And when I talk of pre-authorization, it means those are requests that will be submitted electronically, and our case managers are able to deal with them electronically, and they're able to, the facility is able to see them on their head on the real time. So a lot has been done to deal with issues of fraud. Now, going to the second question in regard to when both of myself and my spouse are in employment and we are being deducted. Now, according to the current law and even to the amendment that is being done, for an employed person, and that goes to even what Mwangangi mentioned earlier, is that we are working on a social principle that those ones who are able to cover those ones who are not able, the poor. Now, one of the ways to ensure that is done is that for that employed person who has an income, they're able to contribute so that they're able even to caution that person who is maybe contributing not very little or even not able to contribute. Because from the picture that was pointed earlier about the high payout ratio of the informal sector, one of the ways we have been able to actually be able to remain afloat even with those kind of payouts is that because of the contributions of the employed people who are not accessing, who are contributing far much more than what the informal sector is contributing, we have been able to caution those high payouts in the informal sector. And so we continue in the same way that for every employed person, by the fact that they have an income, they'll be deducted, whether you and your spouse are working, and that way you're able to build a good revenue base, which is going to be able to take care of the UAC as we move forward. So it remains that for those people in the informal sector who the government is paying for, or they are contributing voluntarily, for those ones, they'll pay per household. But for any employed person with an income, a deduction is going to be made from the income from both, from the income from both of them. Thank you.
Thank you, Wambugu, for answering that so comprehensively. And we are officially out of time. I want to thank you all for attending this webinar. Unfortunately, I didn't get to all the questions that have been asked. I tried, but we will get back to you on the questions that we weren't able to answer in the webinar. And I just want to wrap up by saying that, it's very good to hear from all my panelists that UHC is a journey, and so nothing is cast in stone, and so there's still room to discuss some of these things. There's still room to negotiate on some of these things. And the second thing is that I'm very happy that the CAS has actually invited the private insurance industry to have a conversation with her office so that we can have the relevant conversations about benefit package, provider payment mechanisms, and so on. And so watch this space for a follow-up conversation. Thank you so much for joining us. I hope you gained a lot from this webinar, and we'll see you in the next one. Have a good afternoon.